Well, thanks everyone for joining the next edition of At the Elbow. Today I have Dr. Sumerauer, who is the Assistant CMIO at Rady Children's. And Dr. Fair warning, you and I have known each other for a little while, and I've always enjoyed both your insights, but also your great quotable quotes, which are many, and also insightful. So I'm going to be peppering those throughout the conversation because I think they really frame up a lot of what we're going to talk about. Notably, I think the first one is...
don't get me in trouble, all right?
Believe me, these are all PG quotes, but this
good.
Particular one is great. It talks about I think, which frames up everything, right, is the whole notion of evidence-based decision-making being leveraged by both clinical and IT. And what we'll talk about today is how you were able to leverage evidence-based decision-making in managing through the challenges you were having at Rady Children's to improve clinician satisfaction. And maybe to start off, and thank you for sharing time with us, and a quick shout out to the Oracle Millennium Users Group, which is helping sponsor the podcast today, or the webinar today. So you've had an interesting journey into the intersection of clinical and IT. Can you talk to the audience a little bit about your background and how you got your start and entree into this particular position?
Yeah, sure. First of all, good morning, everyone. Thanks for joining us, as Thomas had said. Thomas, thank you for having me today. My path to clinical informatics really began out of necessity. I started my own practice. First of all, I'm a primary care pediatrician by background, and after finishing residency and going to work for a practice, I ended up deciding to start my own practice in 2003. And I was in Northeast Ohio in the Cleveland area, and I'm proud to say that I was one of the first practices in Northeast Ohio to be completely electronic. But because I was an upstart, I didn't have deep pockets, and I didn't have a tech team to support me. So I was the guy. And I taught myself how to hardwire a network, how to create a secure wireless network, how to spin up servers and clients, even how to start working with SQL databases. And yeah, it was a great education. I mean, when I say necessity, I mean it. Of course, I interviewed a couple different companies, and one of the companies that came out, one of the vendors, wanted to charge me $80,000 as a startup fee and then $10,000 per month after that. And at the time, I was starting a practice. I myself didn't have a guaranteed income, let alone the fact that I'm a pediatrician, and we all know that we're the lowest paid specialty in medicine. So I was stuck, but I'm very fortunate that I was stuck because I learned a lot, and I saw immediately how this technology could not only support me as a physician and make my life easier. Not sure that panned out necessarily initially for the masses, but I think we're getting there. But also how it could benefit patients and the healthcare of our patients. So that's how I got started, and then I evolved in that role. I worked for University Hospitals in Cleveland and began my leadership journey there as I went back to work for them a few years later after selling my practice to them. It's been a great journey. It's been a great journey. It's one of these things in life where you take a pause at one point, you look back and you say, oh, that's what I've been doing for the last 15 years. So yeah, that's how I got started.
Well, it's clear where you might have started out with a clinical background, you definitely adopted IT, because I don't think I can count on one hand the number of clinicians that have ever said the word SQL Server database to me. So you definitely acquired some technical knowledge along the way for sure. So I mentioned you have some insightful quotes. I think one of the ones that frames up everything we're going to talk about today is the one where you speak about the ultimate customer of all of us, right? Whether it's the vendor or IT or the clinicians, and the ultimate customer being actually the patients we're all serving collectively. Can you talk a little bit about that and how that sort of framed up what you were doing at Rady Children's when you and I ended up meeting each other at the class summit about a year ago?
Yeah, we all talk about the customer being, when we refer to the customer in IT, we're really referring to the end user. But I feel very strongly that the patient is our customer. And I keep threatening to have that painted on the wall behind my desk. I think it's always important to keep that in our sights. Because when we refer to the end user, what we leave out of the question is the patient. And if it weren't for the patient, there wouldn't be a need for the technology. As a physician, my job is to focus on the patient. And an important part of this is to listen to my patients, and in my case, their parents and their guardians. As an informaticist, my goal is to give my colleagues the ability to practice the highest quality medicine in the most efficient manner. And by efficiency, I don't mean quick. I mean, certainly there's an aspect of that, but I also mean to be able to practice high quality in a high reliable manner with quality outcomes. And a big part of that is to listen to what my clinicians, my end users are experiencing. It's actually why I continue to practice medicine as well, in addition to my administrative role. Of course, I want my colleagues to be able to practice in a way so that they're not slaves to record keeping. But ultimately, all of what we do is for our patients.
And so you mentioned your colleagues and you mentioned clinicians. As a CMIO, you're sort of bridging the gap, if you will, between clinicians and IT. Can you talk a little bit about the role of the CMIO? You and I have talked about quite a bit about when CMIOs actually first started, the evolution of the position. Can you talk a little bit about the position and how do you balance those two, maybe not competing priorities, but how do you bridge that gap between the two?
So as an informaticist, I work at the intersection of the technical and the clinical. You know how I feel about this, right? I mean, and I've told you this before, and I'm the associate CMIO. As the associate CMIO, as the associate CHIO in our organization, as the CHIO or associate CHO, what we really do is support the entire enterprise. And so because of that, we have to have rather lofty goals and a lofty mission. And so that's why I say things like, I want to give my colleagues the ability to practice the highest quality medicine in the most efficient manner. That's the end goal. But your question is, how do I bridge those two? And it's important to not only work in the clinical space and understand what's going on clinically, but it's also important to have the technical understanding of what we're providing our end users. And so bridging those two together really means listening and using the clinical skills of listening that I've learned over the years and applying them not just in the clinical space and not just to my colleagues in the clinical side of the house, but also on the technical side, and listening to what the technical experts are saying and what they're bringing to the table.
So in that vein, you and I met at the class summit, right, in Utah about a year ago. And, you know, one of those standing tables at one of the breakouts, I believe we were standing there talking and pivoting now a little bit to what was going on at Rady Children's. And, you know, class is populated by clinical informaticists, right? A lot of clinicians there, less IT folks. And you were telling us a little bit about the challenges that you were having. Can you tell the audience, as we pivot now to talk a little bit about the use case there at Rady's and the challenges you had and how you were able to resolve that, and the team was able to resolve these. Can you talk a little bit about what was going on at Rady's at the time?
Yeah, on a very specific level, we had a clinical group that was complaining of slowness. And from a technical perspective, when we looked at the systems in place, everything seemed right. The equipment wasn't at end of life. The bandwidth was appropriate. The switches were fine. The wireless was solid. But yet our end users are complaining of dropped connections, slow response time, spinning wheels. Patients were waiting. The waiting room was filling up. So there was a disconnect. One side had a certain experience that they were telling us about. The other side was saying, but everything's right. So how do we bring those two together? And I remember the conversation we had, and it was actually quite a lively conversation on one of our breaks. And what is it that we said? We can bring our end users the best EHR. It can be set up. It can have the greatest CDS. It can be fantastic. The order sets are right. The ease of ordering, the ease of taking notes is there. There aren't too many clicks. You don't have to wait for too many screens to open up. But if it's not being delivered in the most efficient manner, in the most reliable manner, it's not the best EHR. And so it's not just about the EHR product, but it's about the delivery of that product and the reliability of the systems behind it that are important. And that's where these two areas need to come together and be melded together.
And I remember when we were, go ahead, sorry, Roger.
Oh, no, go ahead.
Well, I remember when we were talking, and this is not an uncommon conversation, right? Which is everything looks fine. We're getting all green lights from the IT delivery infrastructure as well as the EHR application. Everything seems to be fine, or it's reported to be fine. And yet we're still having clinician experience issues. And the standard way of receiving clinician feedback is really not evidence-based, is it? It's really difficult to, can you talk a little bit about how you get that data from clinicians, whether it's rounding or surveys and things of that nature?
So I think historically, and I can also speak to our organization, it's been about rounding. It's been about the feedback we get from our end users, telling us about the issues they're having. It's kind of like healthcare education in a way. You hear about when you do things wrong, but you don't get time to figure out why you did things right. And similarly, we gather this information when people complain about something that isn't going well. Is there much monitoring going on of the systems in place to ensure that systems are reliable, that they're working efficiently and giving our end users what they need? I have to keep my sights on my customers. And again, I'm going to come back to that statement. My customer is the patient. And the end users, the clinicians, the associates, they're the front line. They're the conduit to our customers. So when I have a group of clinicians telling me something isn't going right, I need to listen because it's affecting my customers. It's affecting my patients. And from the technical perspective, it may seem like everything is set up for success, but if the end users are telling us a different story, something has to be investigated. So how do you investigate that, right? What have we historically done? So we round. Can you reproduce what's going on there when you're there visiting with the end users? It's hit or miss. It's not always reproducible when we have the educators, the trainers, or the analysts on site, or the network engineers, or the endpoint engineers. So we needed to have a better look at what was going on. And so we're currently in Oracle, Cerner Health hosted sites, or cloud-based. we relied on the data that they provided us at the time for what was going on their end. And we relied on the experience of our users. But we had no way of actually looking at all of the connections, all of the hops in those connections that occurred between when the end user used our technologies and when it was received in our server farm. We had dissatisfied users. So in this instance, what were we going to do? Could we reproduce the issues with our rounds? As I said, not necessarily. Did we need more servers in the server farm? Did we need more bandwidth? Was Citrix functioning as it should? Did the laptops need to be replaced? Did end users have too many web pages open? We could have thrown money at all of this, but would that have been very systematic? Would it have been process driven? Would it have been evidence-based? And you've heard me say this before, we practice evidence-based medicine. Why don't we practice evidence-based information technology?
Yeah.
It kind of reminds me of when, as a clinician, some of the clinicians on the call might appreciate this. I'll have a parent come in and they'll say, I want you to run some blood tests on my child. And I'll say, okay, what is it we're looking for? I just want to know that everything's okay and that nothing's wrong with them. And my response to my patients who've asked me to do that over the years has always been this. Asking me to just run blood work on your child is like handing me a handful of darts, pushing me into a dark room, closing the door and saying, now find the dartboard by throwing the darts. You need to know what you're looking for. And in this case, in our information technology case, we needed to have the data to understand where were the potential pitfalls, where were issues occurring that we might be better able to focus in on solutions to improve those. So unless you have an idea for what tree you're going to go barking up, it's not very process driven. It's not evidence-based at all. And so that's where you came in, and thankfully through the foresight of my boss, my chief, who had been, wanting Goliath to come in and take a look at these speeds for a while, we were able to do that. And that's where we had you come in and do a proof of concept with us.
So can you talk a little bit about?
I'm sorry, I want to get back and say, rounding is catch as catch can, but real-time data is real-time data.
So can you talk a little bit about that? Because I know that when I first talked to you at the summit, and I said, doctor, we can tell you where, imagine doing an at the elbow rounding with 100% of your clinicians at the same time on demand and getting very specific, technically aware feedback from your clinicians, right? And I think you were maybe a bit skeptical, but it was great that you followed up with us after the summit and we were able to come and work with you and the team. Can you talk a little bit about when you started seeing the data and how that changed a little bit of the conversation internally? And the dialogues were great. I mean, I believe, Oracle was they were on the call and they were extremely helpful and willing to work. The IT team was very engaged. They everybody seemed to want to solve the problem, but sort of lacked the data to be able to take action. Can you talk a little bit about how that came about? And when we first started reviewing the scorecards together and sort of saying, whoa, wait a second, this is where some of the issues are.
Once we had the evidence, we could correlate to the experiential reports, right? Once we had data in real time, then we could, even retrospectively, in a very powerful way, go back and say, this user complained of this issue at this time, here's what was going on. And that's really when the light bulb started going off for us. In this whole process, the Oracle team came to campus. They rounded alongside with our teams. We went around to the practices to look at the issues that were going on. But the evidence helped support where issues were and where issues were not. And that was huge, right? That was really important, because that's really when the finger pointing stopped. And finger pointing makes it sound so kind of malicious, right? Like, oh, it's them, it's them. It wasn't really that. It was just like, well, it's not us because we have everything right, so it must be that. But all of that was based on what we thought we knew, not what was actually going on.
Right.
Does that make sense?
Yeah, absolutely.
Yeah.
Well, in the absence of data, people listen to whomever is speaking the loudest to the right people, right? And
or people get stuck in their own weeds, right?
Right.
People see their trees, but they lose sight of the forest. And in this case, that's really what was going on. All of my systems are working properly. All of my systems are working properly. We're having slowness. So there was a disconnect, right?
Right.
And that's where the data really helped bring us together on what was actually going on.
Well, you know, it's interesting. We've been over the years on many calls, you know, call them SWAT calls or major incident bridges or things like that, with multiple different EHR vendors. And it's really a sort of a curious thing. You get 30 sometimes people on a phone, 20 people on the phone, and you pull them all together. We can't seem to find the root cause of the issues. Raise your hand if your particular piece of the infrastructure is the problem. And obviously that never seems to go well, you know. So having objective data that everybody can get their arms around, so that problems can be pinpointed and actions can be taken. Can you talk a little bit about where the problems existed or what actions were taken? And how that process went. Once we had the data, how did the process flow from there to be able to improve clinician experience?
Yeah, you know, as I said, once we had the data, that sort of that finger pointing again, that was more like it's not me, but so it must be something else. Once we had the data, that sort of stopped. And once we had the data and we knew where some of the issues were and where they were not, with laser focus, we were able to increase bandwidth. We replaced 2 of our circuits, and we got rid of a wireless access point because we realized there were too many and they were interfering. All of this was based on the evidence that we got back. And the results were noticed immediately. And the emails and communications of we have problems, we have issues, they stopped and they were replaced with thank you for listening to us and for finally fixing this problem. And that came directly from our clinicians. And that was a huge feel-good moment, because it underscored for me that my high, lofty, overarching goal, I was actually doing it. I was actually heading in that direction. And as an organization, we were supporting our clinicians and providing improved care for our customers, our patients. That was great. But it was because of the data that we were able to make these very laser focused improvements and actually see the forest for the trees.
Doctor, you communicate in a specific way to your clinicians, right? And I believe that you've communicated some of the impacts of these and quantified them as well, right?
Yeah, so my chief and I, we publish a monthly newsletter from the office of the CHIO that goes out to all of our clinicians. And I'm not a Pollyanna, so we don't just like you cheer for what's going on. We publish the good with the bad. But in this case, we really had some good stuff to publish. And so from August to October, we were following the data that we were getting back in our speeds. And I like graphics, and so I like speed dials and things. And so we were able to publish in our newsletter in November that from August to October, our average network speed, connection speeds, improved 13%. And that was based on the data. So not only did we have the evidence to make changes, but we also then had the evidence to report back to our end users and let them know what we had been doing and how it had improved their experience. And that, I think, is huge. I think it's huge not just for us as a pat on the back, which is not what it's about, but to communicate to our end users that we are listening to you and we are addressing the concerns you have. And here's what we've been able to do. You know, I'm going to go back to a comment I made a little bit ago in our conversation just now. And I heard this at a talk I went to a while back. I'm an educator as well. I teach medical students and I teach residents and have my entire career. And so much of medical education is based on correcting what we've done wrong. But we never really give our students the ability to take time and understand what they did right. And that's the analogy here. And that's the analogy I made a little bit earlier in our conversation. We shouldn't just focus on what we're doing wrong. We should also pay attention to what we're doing right. And one of the conversations I've had with our team about this technology is that it shouldn't just be used retrospectively, right? We talked earlier about how we can use this data to correlate retrospectively with what's happened. But if we're really using the data that we get, we should be using it in a proactive way, right? We should be looking at the reports daily and looking at what's going on in our network, or be able to look at the dashboard. And if we notice that a problem has happened in the past where A, then B happened, and then C happened, and that was the event, if we notice that happen again, we need to start saying to ourselves, oh, there's something going on here, right? Because when B follows A, C always comes. So if we see that A and then B are happening, we should be able to intervene and make some changes so that C doesn't happen. So I kind of went down a couple different directions there, but I think what I'm trying to get at here is that's the beauty of having this evidence and having this information available to you. It's not just information that you can use to fix, sorry, I keep looking at my lighting because it's kind of dark. It's not just information that you can use to figure out what happened in the past. But if you think about it in a proactive manner, it's information that you can use to prevent issues from happening in the future, or at least recognize when those patterns start to develop to abort a problem before it happens.
So with the data you're referring to, right? There's another comment that you often make, which is, you know, there's an artificial separation between clinical and technical teams. How can you talk a little bit about that particular statement for some context and your opinions around that?
I think the first time we talked about this was in Salt Lake at class, but you can't have one without the other. And I feel like in some ways that informatics and information technology are artificially separated or siloed. And they can't be. It goes back to the diagonal relationships I mentioned earlier between my chief health information officer and my CIO, and my associate CIO and I, who have a great relationship and work together to solve these issues. We have strived. I'm fortunate to be in an organization where we have strived to break down those silos. I'll give you an example. I was working with someone recently who was trying to coach a group of clinicians through providing better information to patients after a visit occurred. And they had the solution. They were able to tell the clinicians what to do, but the clinicians weren't really satisfied with that solution. So I asked the person who was trying to coach the clinicians, I said, have you ever seen how this works in the system? What do you think their answer was? No. They had never actually gone into the system that they were coaching the end users through to actually see the steps the end user had to take to publish what they wanted them to publish. And that was kind of mind-blowing.
Yeah.
I mean, how can you expect to solve problems if you don't fully understand them, right? If you don't understand the technology behind them, if you don't understand the culture that drives all of this. And that's why I so strongly believe, that's my example of why I so strongly believe that IT and informatics cannot be artificially siloed. It is an artificial separation and it doesn't make sense to me. And I mean, look, I'm going to be the first to admit, I don't have the complete technical expertise to solve the technical problems on the back end. I would also argue that the technical side doesn't have the clinical expertise either. When I was in private practice, I used to have my nurses follow me into the exam room sometimes because I wanted them to see the complexity of the doctor-patient relationship. I wanted them to see what happens when the door closes. It's much more complex than most people realize. And that's why this needs to be a fully developed partnership between both. As I mentioned, I'm fortunate. I'm at an organization where we see that. And again, where my chief CHIO and my CIO, they work together as a dyad, and where my associate CIO and I, as the associate CHIO, have developed that diagonal relationship as well. I think it's super important.
And, doctor, you mentioned something about, bringing the nurse into the, to experience the patient interaction. Can you talk to us? You hear terms like slowness, EHR latency, and things of that nature. And one of the most expressive times that we hear those complaints are when that takes place in front of the patient, right? When it's at the point of care that the clinician may have a very good EHR application, but they can't access it because of slowness, latency, that type of thing. Can you talk a little bit about how that feels as a clinician to be experiencing a technical barrier to care or a challenge when all you're trying to do is to have a conversation with the patient, possibly explain lab results or something like that, and there's some technical difficulty accessing the patient record?
Well, it's frustrating, right? There's your one-word answer. It's frustrating. I can't provide to my patient what I need to provide to my patient. And that's why this technology is important. But more than that, and in some ways, I think you teed this up, Thomas, very well done. Put yourself in the patient's shoes. What's the patient doing? Waiting. Waiting for results. Waiting for their note. If a clinician, if a physician or APP can't get the result, the patient's waiting for the result. If they can't write a prescription, they're waiting for the prescription. If they can't sign off on the note, they're waiting to get that information in their portal. And I'm going to use a quote from a colleague, someone I had the pleasure and honor of working with back in Cleveland, Peter Pronovost, who's coined the phrase, waiting is suffering. Waiting is suffering. If I'm a patient and I'm waiting for my CAT scan results because I'm here for follow-up for the radiation therapy that I had, I'm suffering, waiting for that result. If I'm a mom who's waiting to get the CBC results on her febrile child to find out what further tests need to be done in the emergency department. And that system is slow. I'm suffering because I'm worried. What's next? What happens now? So that's frustrating for the physician to not be able to provide that information. But our customer, the patient, what's it doing to them? That's where our focus has to lie. That's why this is so important. That's why we can't have this artificial separation. That's why we have to bring these worlds together. And the technical side needs to understand the clinical side, and the clinical side needs to understand the technical side. And that's why where I sit at the intersection of the two is so very, very important. And it's not just me, but it's all of our teams involved in bringing this forward to our customers, our patients.
And Doctor, one of the things that we hear when we're talking to folks is, and they might come away with this saying, okay, this is great, but it probably took many, many months and millions of dollars to be able to have any sort of meaningful improvement. 13% improvement, that must have been incredibly expensive and cost a lot of lives and spent a lot of capital to be able to arrive at that. Can you talk a little bit about, because when I tell people, if I try to recount this story or many other stories we have, there's sort of people are skeptical that you could have data like this so quickly, be able to pinpoint issues so readily, and that the fixes to those issues are not as difficult as implementing a new EHR or training staff or changing application workflows, clinical workflows, and things like that. Can you talk a little bit about the timing and the work effort involved here?
You asked about cost, you asked about timing, you asked about work effort. I'm going to use a medical analogy. What's the most expensive type of care for patients to get? Emergency room care.
Right.
Why? Because in an emergency room, the physician doesn't really know the patient, is gathering a history for that moment in that time, and typically needs to order a whole battery of different things to understand what's going on. It goes back to the analogy of having the evidence, right? Or the story about having the evidence. In technology, if you can laser focus, just like in medicine, the treatment to the disease, your outcomes will be better and your costs will be lower. All of us can throw everything at the patient and our technology stack, including the kitchen sink. That's a really expensive way to go. But if you know what you're treating, if you know where the problem lies, if you know what the disease is, and you can laser focus that, your treatment is more effective and it's more cost effective. If we think about cancer therapy, there's much discussion these days about theranostics. Theranostics is therapeutically driven interventions based on the diagnostics behind it. Similar thing here, right? And I think in healthcare, we're moving in that direction. Patient-specific treatments, disease-specific interventions. And that's what I'm talking about here in information technology as well.
So, Doctor, in closing, do you have any advice? And we sent out an email to people and asked for questions prior to the webinar. We had a couple. I think to give us the ability to end this on an interesting note. What are other CMIOs or assistant CMIOs, clinical or IT executives more broadly, that are having issues like this? Any sort of general advice that you can offer? Besides working as quickly as you possibly can with Goliath Technologies.
Well, Goliath is important, right? It's not the panacea, but it's an important piece of the puzzle, at least from where I sit and how we've been able to leverage the technology. I've got some thoughts and some advice. My advice is get the data, advocate on behalf of your end users, your patients, advocate on behalf of your analysts and your technology colleagues. Break down the silos and build bridges to improve the communication and understanding between the technical and the clinical sides of the house. Break down those silos. In the end, and we've talked about this before, in the end, I see a truly high-performing digital healthcare system as one that listens to its end users, makes evidence-based, data-driven decisions, understands not only the capabilities of its current technology stack, but also the limitations, is never afraid to take technological risks, and most importantly, never, ever loses sight of its customer, the patient.
So there's a question here that I do want to ask because of all the questions. One is frustrated clinical executive was the sort of the heading. And what do you do if you don't have a good relationship with IT or a productive relationship with IT? How do you break that standoff, as I think the word is that they used? And frankly, Doctor, we've heard this a number of times, right? Talking at various meetings and things like that, is the sort of there, in your view, there's sort of an invisible artificial separation. In some organizations, there is actual separation, right? How do you get the two groups to work in concert if you're in that situation where you just want everybody to be on the same page and work together to resolve issues for the patient, right?
Well, Thomas, I mean, that is, for many, the complexity and the problem, as the frustrated clinical executive has pointed out. Honestly, it's about relationship building. And as cliche as that sounds, when I arrived here, one of the first people I reached out to at the time was my CTO, who then became the associate CIO, who is my partner. As the associate CHIO, he and I worked together. And one of the first things we did was develop our relationship. And that's not just inside the office, but that means spending time outside the office, really getting to know someone and really getting them to trust you and developing your trust of them. So there's the relationship building part of it. But I think the second part of this, and this is not a plug for Goliath, what I'm about to say, right? Though I know you're sponsoring this talk today, but have the data, right? You might not, if you don't have Goliath, fine, think about getting that, but back up what you're trying to accomplish. Get that information, do a class survey, right? Go and get the information you need so that you can actually prove what you're saying. Because as the example that I highlighted, your end users may be complaining, but everyone thinks everything's okay. And in some cases, sometimes the end users, I like to call it Stockholm syndrome because it's similar to that. They just get used to waiting 70 seconds to log on first thing in the morning. That's unacceptable. Right. Compare that to what national standards are. Get the information so that you can say, look, I realize that we've not had a great relationship historically. My predecessor might not have developed this very well, but I'm telling you that our end users are having a hard time. And because of that, our patients, who are really our customers, are suffering because they're not able to access their records. They're not able to get their scripts in a timely fashion. They have to wait for their results. They have to sit there in the room. The waiting room is backed up. Patients are waiting. This is dissatisfying on so many levels. Get your patient satisfaction scores. Get your end user satisfaction scores from KLAS. And use that data to drive the relationship building and the change that you need. That's what I mean by evidence-based technology. We do it in healthcare. Do it in what you're doing technologically.
And that would be a highly performing digital health system that's able to do that, right? You're taking,
as I said, listens to its end users, makes evidence-based data-driven decisions, understands not only the capabilities but the limitations of its technology stack, is not afraid to take technological risks, and never, ever, ever loses sight of its customer, the patient.
Doctor, thank you so much for your insights today. We appreciate it.
Thank you, Thomas. Thank you, everybody. Have a great day.
Take care.
Bye-bye.